studies. Okay, what if a lady comes in with positive nodes in her arm, we give her chemo, and they go away? What do we have to do? Do we still have to clean out her underarm? It doesn't look like it right now, but those trials are still accruing patients. And the same thing, what if they only have 1 or 2 positive nodes, but their whole underarm isn't chock full of tumor after chemo? Do we still have to clean out their axilla? It's not looking like it. So again, less is looking like it's going to be more. How do we do this sentinel node biopsy? We inject a radioactive tracer and a blue dye in the area of the tumor or around the nipple. It drains through the lymphatics, and the node that either turns blue or takes up the radioactive nucleotide is the one we sample. And if that one's negative, we assume that that's the most likely one to contain the cancer, so the rest of our underarm is probably negative too. So that's how we get it. You know, one tiny incision about an inch or 2 versus having to cut them all up. Why does this matter? If you look at the picture on the patient's right arm, she's wearing a lymphedema sleeve. Lymphedema is not predictable, and it's a lifetime risk. That risk is increased in patients that have axillary dissection, especially in women who also have to have radiation as well. They have up to a 30 to 50% chance of developing lymphedema. Lymphedema specialists are physical therapists. A lot of times we'll send patients there for education, either pre or post-op, just so they know early detection, early intervention, exercises, etc. There's no real cure once somebody has lymphedema. We can get it better, but it can flare anytime, and it's not always going to go away. So we don't want this. It looks awful and miserable. What else can we do, or what are we doing to reduce our recurrence or our risk of getting cancer in the first place? So we have endocrine therapy. As Coach B said, that good old drug tamoxifen was developed in the 1960s. So really, that's as far as we've come. Well, it's been in 20 studies so far. Tamoxifen decreases our risk of breast cancer recurrence in both breasts or in a woman with high-risk like family history, by up to 50%. We use that in premenopausal women and in some postmenopausal women. Bad things about tamoxifen: you have an increased risk of uterine cancer, so you've got to monitor that with your OB, no matter if you're pre or postmenopausal, and you have an increased risk of blood clot. So in smoker or someone who has a history of blood clot, we can't use that drug. But it doesn't create a whole lot of menopausal-like side effects. It's better tolerated in general by our patients. You have another medication, an aromatase inhibitor, which is a total estrogen blocker. They don't have the risk of uterine cancer. They don't have the risk of clot, but it can make your patients miserable sometimes because essentially you're amplifying menopause. So, you know, some women get through it with no side effects whatsoever, but sometimes that's unbearable. And ultimately, patients still a human, right? We have to treat them like it's a lifestyle decision too. So while the drugs are great, if they're not tolerable, I'm not ever going to force my patient to do that. We also have genetic testing. 8 genes so far have been identified to be associated with breast cancer. We'll get to that in just a second. And some increased screening and surveillance. We can skip that slide too. So lifestyle modification. Several studies of late have shown that 150 minutes of aerobic activity and 2 sessions of weight training or resistance training a week actually decreases up to half of your breast cancer risk or your breast cancer recurrence risk. So a healthy lifestyle actually does matter in this case. Moderate alcohol use. I'm not going to bore you guys with the biochemistry, but alcohol can eventually be converted into estrogen, and it's the waxing and waning levels of estrogen that can increase our risk of breast cancer. So moderate alcohol use, meaning no more than 4 drinks a week, can decrease your risk. And then weight control. Our fat cells actually make estrogen. So if we can decrease our weight by, I think it's about 5%, you're decreasing your lifetime risk of developing breast cancer or recurrence. And genetics. Who qualifies for genetic testing? According to the American Society of Breast Surgeons, all women with breast cancers need to be considered for genetic testing. That doesn't mean we would do it to everybody, but everybody needs to be considered. That's a new recommendation from this past spring. So any woman under the age of 45, any woman with triple negative breast cancer under the age of 60, any woman with 2 or more first-degree relatives with breast cancer or GYN cancer, or metastatic prostate cancer in a male in their family needs to be considered. Any male with breast cancer, and anyone with an extensive family history of breast, ovarian, other GYN-related cancers, melanoma, pancreatic, or colon cancer. All of those cancers so far have been linked to a breast cancer mutation. Those are the 8 genes that have been associated with breast cancer. The ones that are in the mainstream